Chairman, dear colleagues, I'm honored to be here to show you an emblematic clinical case of an elderly patient with degenerative mitral valve regurgitation, whose current treatment option will be analyzed. The patient is an 81-year-old man with a BSA of 1.78 square meters. He suffers from stage 1 hypertension, moderate stage COPD due to emphysema, and moderate chronic kidney disease with an estimated glomerular filtration rate of 45 ml per minute. He is symptomatic in functional class NIA 2, and the ECG shows a sinus rhythm with an heart rate of 70 beats per minute. The transthoracic echocardiography shows a severe degenerative mitral regurgitation due to P2 flail with an anteroposterior diameter of 32 millimeters, an eccentric jet with vena contracta width 7 millimeters, effective regurgitant orifice area 44 square millimeters, regurgitant volume of 51 ml per beat, and Quanta effect. No mitral stenosis, a mild posterior annulus fibrosis. The left ventricle function, diameters, and volumes are preserved. The left atrium is enlarged, and there is a mild tricuspid regurgitation. Here you can appreciate the transesophageal echocardiography with 3D reconstruction, which confirm the severity of mitral regurgitation due to P2 flail. The CT scan reveals 2 large air bubbles in the upper lobe of left lung, and to better investigate the pulmonary function, a spirometry was performed. A reduction of FEV1 and TIFNO index confirmed the moderate COPD. So a risk evaluation was assessed using Aeroscore 2 and STS score. The Aeroscore 2 is 2.83%, and the risk of mortality according to STS score is 4%. The composite risk of morbidity and mortality is 26.1%. And beside these scores, a frailty assessment was performed, whose results indicated a mostly independent patient without cognitive impairment. So, which are the treatments available? Surgical strategies include full sternotomy and right mitral thoracotomy. In both cases, a mitral valve repair can be performed. On the other hand, we have transcatheter procedures, mainly consisting of edge-to-edge mitral repair and transapical chorda implantation. The last option is optimized medical therapy. So let's analyze each available option with pros and cons. The mitral valve repair in full sternotomy is usually less time-consuming, technically less demanding due to an optimal exposure, but on the other hand, it has a higher physical impact. The mitral valve repair in right mitral thoracotomy usually offers a reduced trauma and pain, a shortened ventilation time, and a superior preservation on lung function, and consequently a faster recovery. It has been associated with fewer blood transfusion and a lower risk of wound infection. Against this approach, in this case, there is the emphysema of left lung, a longer CPB, and a technically more demanding approach. Another available option is MitraClip. In favor of MitraClip, there's the complete adherence to the suitability echo criteria. In fact, the optimal patient suitable even for startup centers should have a pathology in segment 2, no calcification, a valve area above 4 square centimeters, a length of posterior leaflet above 10 millimeters, normal thickness and mobility of leaflets, a flail size below 15 millimeters, and flail gap below 10 millimeters. And all these criteria are satisfied. Against this approach, there is the absence of a concomitant restrictive annuloplasty, a higher incidence of residual mitral regurgitation, and the mid-long-term durability. Another option is transapical chorda implantation, and Neocord has been the first device to be clinically approved. In favor of this approach, apart from being a beating heart procedure, is the correct leaflet to annulus index, which is a strong predictor on less than mild mitral regurgitation at 1 year of follow-up. Against this approach, there is the absence of concomitant annuloplasty and the uncertain mid-long-term durability. The last but not the least option is the optimized medical therapy. In favor of this approach, there's the good quality of life and the age of patient is just above the midlife expectancy, both in Europe and in Italy. Against this approach, there's the unpredictable clinical evolution, which may worsen without a surgical or transcatheter procedure. In conclusion, all therapeutic choices appear reasonable. So how do you make your choice? Thank you.
I think this is an excellent opening for the discussion on the mitral. Maybe we can take a short poll. You don't tell us what you did. We ask you after we had the presentation, okay?
Okay.
So
Thank you.
we have 5 options. Who would do optimal medical therapy?